Okay, so we are moving our discussion to amputation, which is the removal of a body part, and that is usually an extremity or a limb, although it can involve the ears, the nose, the tongue. Those things are also able to be amputated. Amputation can include an entire limb, which would be a disarticulation point through the joint, or it can be at any point along the extremity, including just parts of digits. But it is a significant cause of disability and body image disturbance in people. And there are about 2 million people in the United States living with amputation, so this is a significant problem. There are two broad categories of amputation. We have traumatic amputations, and these are amputations that occur. Some of them might be a result of casualties of war, especially with the Middle Eastern conflicts. We saw a lot of people coming back after being injured with the IEDs, or the implanted explosive improvised explosive devices, rather. I'm sorry. Or it can be as a result of a car accident or an industrial accident, people who get their fingers caught in a saw or a hand or part of a limb. Traumatic amputations, about 2/3 of them involve the upper extremities, and the remaining third goes for lower extremities. But the other category is non-traumatic amputations. And some of the reasons for a non-traumatic amputation could be infections of diabetic ulcers. Gangrene in particular causes a lot of problems. You might have amputations as a result of cancers of the bone, metastatic bone cancers, or even cancer in situ, where you want to remove that extremity before that cancer can spread to vital organs. You can have amputations for infectious processes like osteomyelitis, where that infection does not respond to treatment. Deformities. For example, people who were born with extra digits in the nursery will do an amputation by constriction, where you tie those digits off and they eventually become necrotic and fall off. Or, there was one video on YouTube of a woman who had elected to have an amputation because she was born with a club foot and all her life suffered disability and pain, and was told by her orthopedic surgeon, after many other procedures on that foot, that amputation would give her the best chances. She could be fitted with a prosthetic and do things she had never done before, like walk more than a few steps without assistive devices, or she was unable to work. So this maybe offered her a better solution. You can also have amputations following trauma, not as a direct result of trauma, but maybe they tried to save a leg with an external fixator device or surgery and were unable to do that because of neurovascular compromise. So those are some of the reasons for amputation. You can put that over there. Okay, so I went on the website for the Amputee Coalition. I'm going to give you that website in case you're interested. Okay. Let me make that in a more usable format, and then I'll kind of stick it up here in the corner. So any of this information that you want to double check, or if you want a new perspective, this website was excellent. It had a lot of videos. It had a lot of educational material for patients, for providers, and it gave me a pretty good perspective on how amputees live and what some of the complications are, and how people can live fuller, more productive lives in spite of limb loss. But some of the statistics that came out of this were pretty staggering to me. There are nearly, as I said, 2 million people living with limb loss in the United States. And among those living with limb loss, vascular disease is the highest percentage. And a lot of that vascular disease is secondary to diabetes. So that is probably the #1 thing that we would want to target. Smokers also have a very high rate of amputations. So diabetic smokers, the literature suggests that they do have more amputations, and those amputations tend to be more proximal. And we'll kind of talk about why why a doctor might choose to amputate at a given level when we talk about that. So trauma accounts for about 45%. Vascular disease was 54%. And then cancer was less than 2%. Excuse me, there we go. The costs associated were more than $8.3 billion, but $8.3 billion in healthcare money, maybe it's just me, but I sort of don't have a really good concept of what $8.3 billion buys you in contemporary healthcare. So that sort of was a concept that was lost on me. But here is something that was not lost on me. And when we talk about disparities in healthcare, this was really shocking. African Americans are up to 4 times more likely to suffer amputation. And that is a very sobering statistic, and something that we, as healthcare providers in America, really need to look at. Because what it speaks to is access to care for chronic conditions like atherosclerosis, like hypertension, like diabetes, that with good care can be controlled so that we can prevent those amputations. So that is something that I would like you to note, because it was just something that struck me as being a very sobering statistic. Okay, so we describe our amputations in terms of where they are and how extensive. Okay, and this picture shows you the different levels of amputation. So let me get a highlighter here, and I'll kind of point out. We can have partial foot amputations. Let me pick a different color for that. There we go. And you can amputate as much as a small toe, a great toe, but that even the amputation of a toe does affect balance and gait, and can really make it difficult for that person. You can do what's called a cyme amputation, and let me draw attention to that here. And what that is you remove the entire foot, but you leave the heel. And the heel is important because that fleshy pad gives you something to walk with when you have a prosthetic. It is more difficult to fit a prosthetic device over cyme amputation because the shape of the limb tends to be bulbous, and you really need to have a specially fitted prosthetic for that. But retaining the heel really does seem to help with balance from what I read. Ankle disarticulation here is removal. A disarticulation when you amputate right at the level of a joint. Then we have below the knee, or transtibial, above the knee, aka transfemoral. Actually, I think they showed it here. Okay, and then there are knee disarticulations, hip disarticulations. So really, the higher up you go, the more function you lose. And they try to preserve as much of the limb length as possible. However, what they need to do is ensure that the residual limb has enough good circulation to it that you're not going to end up with infection, and you're not going to have poor wound healing. You want to have good wound healing, so they might do Doppler studies and decide where they want to amputate. There is a philosophy, or was a philosophy rather, in the past, that you wanted to leave more limb rather than less because you could always cut more off. But what they're finding is that then you expose that patient to more risks from surgery unnecessarily. So they really try to ascertain how much circulation is present in that limb so that they have the optimal wound healing, and that really is the most optimal thing for function. Things for you to remember from this is that the higher you go, or the lower the level, the level of amputation, the higher the function of the residual limb. Okay, that is a general rule of thumb. Also, the higher the level of amputation, the more effort is required to use a prosthetic device. Now, when we're discussing young, healthy patients, that might not matter as much, but who are most of our patients? Most of our patients are older, they're diabetic, they're smokers, they may have many concurrent diseases, they might have heart disease, they might have COPD, they have diabetes. They don't have as much energy to work that prosthesis to begin with. And if it takes more balance and coordination to use a prosthetic device, they're at higher risk of falling. So that is important to remember. And when we discuss the upper body amputations, you need to remember that upper body amputations are much, much more disabling and debilitating than your lower extremity amputations. Think of all the things you do with your hands and your fingers and your arms. Think about getting dressed. Think about brushing your teeth. Think about buttoning things or putting on a watch. Think about cooking and taking care of your kids and taking a shower. All things that you do with your hands and arms that now people need to learn new ways of doing things. And one of the things I liked about that Amputee Coalition is it showed you some videos of people who had lost upper extremities and how they learned to compensate with good occupational and physical therapy. Okay, so we're going to focus our discussion a little bit on different facets of amputation, and the first thing we're going to talk about are your traumatic amputations. And if they occur, and you are the first responder or you're the person on the scene, you should know some emergency care. Okay, so the first thing you do is the first thing we always do is we prioritize our ABCs. You're going to control hemorrhage. Okay, so let's say somebody has lost a hand and now their radial artery is pumping blood. You're going to use direct pressure with a clean cloth if you have one, or something sterile preferably. Again, this is, you know, a site that is prone to infection. Now, what you're going to do with the amputated part, let's say that it is a finger in this case. You're going to take the amputated part and place it in a clean plastic bag. And let's amend that to say clean, dry plastic bag. If you have a sterile gauze, you can wrap that around it. But you do not want to get this extremity wet. So do not put ice directly on the amputated part. I'll put directly on ice because here's the next thing you're going to do. The next thing that you're going to do, let's see if we can make that a little bit smaller and straighten it out a little bit. I'll do that after. Okay, so you're not going to put the part directly on ice. You're not going to get that amputated finger wet, but you are going to place the bag with the amputated extremity in it. You're going to make sure that bag is sealed up really tight. You're going to place it in ice water or on ice and transport it with the patient. Okay, so here you have, let's say, the finger. It's in the clean, dry plastic bag with a gauze around it. Then you take that bag, make sure it is well sealed. You can tape it shut if you feel that you really want to keep it dry, and put that bag in something cold and keep it cold. Okay, and make sure it goes with the patient to the hospital. That is how you deal with traumatic amputation. Now, I'm only going to add this because I just found this out from somebody who does some emergency stuff. Tourniquets. And for this, if you are a first responder, you're going to have to go with whatever the practice is in your area. Tourniquets were always supposed to be a last resort. And the way that you do a tourniquet, you can tie a belt, you can tie a rope, you can tie a rubber tourniquet, you can use like a blood pressure cuff if you have to. But what you're going to do is to get something tight around those vessels and stop them from bleeding. The problem with the tourniquets is that you do sometimes get vascular damage. However, what I heard from the person who is more in contact with the emergency world than I am is that tourniquets are sort of making a comeback. Because people were dying, they were bleeding out. So that is something I will just kind of let you defer to whatever the evidence-based practice is in your area. And I will add that if you are just a bystander and someone around you loses a finger, be a good Samaritan and do the best you can with direct pressure. If that's not enough, you may have to use a tourniquet. Certainly you are going to get EMS out there as soon as possible. I can't imagine anybody who would wait and try to be a hero. You're going to get that person to a hospital that can do the kind of surgery that can reattach that limb. It is possible in some instances to reattach, but time is very valuable in that situation. Okay, so we've discussed traumatic amputation. Sometimes that can be reattached, sometimes not. But the more common amputation that you are going to see is a surgical amputation. So there are some things that the nurse needs to be aware of when a patient is undergoing an elective surgical amputation. And we're going to cover those. Just as with any pre-op, you're going to do your teaching. Make sure that the patient understands the procedure they're going to have. Of course, if they have elected to have a leg amputated, they know that they're going to have their leg cut off, or their foot, or their toe. But you might need to do more teaching based on how that will look, what phantom pain is. You might have to tell them that they are going to grieve the loss of their limb and the loss of function and the loss of their body image. You want to teach that person. Most of these patients, I mean, it was amazing. I was on YouTube watching story after story of people who have had amputations, and most of them are out of the hospital in a day and a half at the most. As soon as they can be up out of bed, they're not bleeding and they're not showing signs of infection, they're out the door. They're either home or they're in rehab. So a lot of pre-op teaching about physical therapy after, the need to shrink the limb to fit a prosthetic device. They're going to need to know the risks of the surgery, bleeding and infection. They should certainly know what pain control options are available to them. So these are some pre-op teaching things that you are going to be responsible for. I'll leave that up for just a second. And another thing that if you are the perioperative nurse, marking the correct limb. I know you have all seen some 2020 or Dateline or some other kind of news media broadcast about patients who have had wrong limb surgeries. And this is devastating. You went in to have your right leg amputated and they took your left leg and now you have no legs. Marking the correct limb is extremely important, as well as doing a timeout before the procedure. Make sure that the marking matches your consent form. And you are not responsible for getting the consent, but if you are the circulating nurse and you're doing a timeout with, say, the anesthesiologist, You're going to read that consent, and both of you and the surgeon and everyone in the room has to agree that the planned procedure was a right leg amputation and not a left leg, if that's the case. So wrong site surgery is considered right now a never event according to Joint Commission. And even when you're not amputating, if you operate on the wrong site or perform the wrong surgery, this has devastating consequences for the person, and you've now subjected them to an operative procedure that didn't correct the problem they came in for, and now they have the recovery to go through on the wrong surgery. So timeout and marking the correct limb are absolutely essential. Antibiotic prophylaxis. Amputations are all considered contaminated wounds, and you are worried still about the risk of osteomyelitis. And the risk here is that you've already amputated, say it's a below-the-knee amputation. If you get osteomyelitis in that distal residual limb, now you might need to amputate further. So we're really going to be careful about infection. So there are two types of surgical amputation procedures. There is the open or guillotine procedure. I'm going to blow this up. I tried to find a good one on the internet that wasn't too graphic, but most of them showed a lot of necrotic bone. The reason that I chose this picture was it illustrated the concept without being too sort of over the top. Certainly, if that's your thing, go ahead and Google open amputation. You'll find all kinds of traumatic amputations. But I caution you, if your kids are in the room, you might want to not put them up on your big screen. So the open amputation, the guillotine procedure, is done usually when there is an infection or osteomyelitis, or the patient is very likely to develop osteomyelitis as a result of the procedure. And so this is left open, and there are drains, and this keeps pockets of pus or abscess from forming, allows the exudate to escape from the site. Eventually, at some point, they do suture those skin flaps. They'll kind of look like this. Now, when you get the patient from the OR, most of the time they're just going to have it dressed and wrapped. So you will not see it the way that the internet portrays the images, the real graphic amputated limbs. So, you know, if you want to look at that a little bit more graphic of a picture, be my guest, but I did not want to put that in the presentation for people who are watching this while they're taking care of their kids. I did have a real picture of a closed procedure because it's just a little less graphic. It's clean, it's been sutured, or it looks like he's in the process of suturing it. And this is where we would suture the doctor would, suture the skin flaps over the bone and allow it to heal. Now, you may have drains on this type of procedure, or you may have wound vacs, but with both procedures, the surgeon is going to try and preserve as much limb length and joint function as possible. Taking away the joint actually, like if it were above the knee, is much more debilitating than a below the knee amputation in terms of maneuvering with a prosthesis, and it does affect how the person can balance. It does affect their risk of falling. So you know, they sort of weigh one against the other. Like I said, they're going to look for tissue that's viable, but they're going to try and preserve as much length as possible. Okay, so when we're caring for the patient post-op, we'll start with assessment. There are several complications of amputation, namely hemorrhage, infection, and phantom limb pain, as well as stump pain, incisional pain. And the nurse needs to have good assessment skills. The first thing that you're going to look for is to assess for any bleeding. It's important to have a large tourniquet at the bedside. This is a standard part of care. In case this person starts to hemorrhage, you need to have a way to stop that bleeding quickly. And this is where that tourniquet is now appropriately used. I know I told you earlier that an emergency care tourniquet is sort of a last resort because you are kind of really putting a lot of pressure on those blood vessels and maybe causing them to not function anymore. But with the patient who's already had an amputation, you are going to use a tourniquet. You tie it very tight and you stop that bleeding. And of course, you would be calling the doctor at the, to come to the bedside and deal with that. The other thing you're going to do, monitor your vital signs very frequently. You're looking for elevations in temperature, which will signal infection, and tachycardia for the same reason. You're going to assess vital signs also for signs of hypovolemic shock, and that would look like tachycardia and hypotension. So those are some things that you're going to look for. You're going to assess tissue perfusion. You're going to use your 5 Ps. Okay, and you want the limb to have adequate circulation. You want it to be pink, light pink in a light-skinned person, and not discolored in a darker-skinned person. The area should be warm but not hot. And you're going to assess the closest proximal pulse. You are not going to try and palpate a pulse right at the amputation site. Say it's a disarticulation of the knee. You're not going to look for the popliteal pulse right over that wound. You're going to look for the nearest proximal pulse. So again, if it's a below the knee amputation, you might go for a popliteal pulse depending on how much limb you have left to do that with. If it is higher than that, if it's an above the knee amputation, you might look for a femoral pulse. So you are going to check your 5 Ps. You are going to palpate that limb for temperature. If it feels hot, you're looking at infection. If it feels cool or cold, you might be looking at a lack of peripheral circulation. And you're going to assess pain. Obviously, this person is going to be in incisional discomfort, but what might not be obvious to you is phantom limb pain. And this is the patient who says, "My foot is killing me. Oh, would you please give me something for my foot?" And you go, "Wait a minute, you don't have a foot anymore." Well, that nerve has memory, and where that nerve was crushed and severed, it remembers that pain. People at highest risk for phantom limb pain are people who had neuropathy and were already experiencing a great deal of pain in that extremity. As I said, that nerve can be irritable. It can remember that pain. There's a few things about phantom limb pain that I want to kind of go into in a little more detail. So let me shrink this a little bit if I can. It'll still be up there if you need to take some notes. But let's talk about phantom limb pain in a little bit more detail. According to your book, on page 1188, Hinkle and Cheever, about 60 to 80% of patients will experience phantom limb pain. And that's early out, it is fairly common, but it can last up to a year. So it's important to assess for this, and it's important to treat it. You must treat the pain seriously, like any other pain. It does originate in the nerves, so initially you might use opioid narcotics in the immediate post-op period. But as time goes on, you probably want to switch to something that's more effective for nerve pain, like gabapentin. Another medication that is used is IV calcitonin, also known as miacalcin or calcimar. And calcitonin is, in the literature, is sometimes the findings are a little bit inconclusive. Some research articles seem to find that calcitonin was effective, especially in combination with other medications. Others found that calcitonin really didn't work well at all as compared to a placebo. But certain types of phantom limb pain respond better to agents like beta blockers, Inderal, also known as propranolol. And beta blockers slow the transmission of nerve impulses. And so pain that is constant dull or burning tends to respond really well to beta blockers. Another medication that is used is Tegretol, carbamazepine is the other name for it, and I probably should have done that backwards, but you get the point. Make sure I'm spelling it correctly. Tegretol is an anticonvulsant, and it has multiple uses in medicine. It's used to control seizures. It's also used in bipolar disorder, but here it's being used again for nerve pain because it does alter the way that the nerve signals are transmitted, and that's best for like a sharp knife-like pain. And gabapentin works well for that kind of pain as well. And then you might have to give muscle relaxants. And the one that's most commonly used is baclofen. So if you were going to do an ATI template on your medications, you might want to do your muscle relaxants and maybe a gabapentin. And you can put those away, and they're, going to be helpful to you. I'm not assigning those templates for today, but at some point in the future you may want to look at those because they are important for the musculoskeletal system. So that is really most of what you need to know about phantom limb pain. What I want to get across to you is that you should never ignore it. The patient is not crazy. They are not drug seeking. If they are complaining of phantom limb pain, they actually have real pain. That nerve has memory. And so I want you to keep that in mind. Okay, so when we talk about the nursing interventions for a post-op patient with a surgical amputation, we did discuss pain relief for phantom limb pain. You also need to address incisional pain. And incisional pain usually does respond best to your opioid analgesics, and you can kind of cover that breakthrough pain with some NSAIDs too, ibuprofen. Again, one of the videos that I saw on YouTube, I was just kind of riveted with these people's stories. But one lady had herself at home. It was her day 2 post-op, and she was complaining of a lot of pain. She had taken her Percocets, they didn't work, and the nursing staff told her to take a leave, and she thought, I just had my leg cut off, and they're telling me to take over-the-counter aspirin, which is what she equated it to. But a lot of times in combination with a narcotic analgesic, those NSAIDs will help with the inflammation and the pain. IV Toradol might be something that you see. Immediately post-op, hopefully that patient might have had some regional pain relief in addition to their general anesthetic. So pain relief is an important part of your nursing care. You can also use all of your non-pharmacological techniques, massage, distraction, relaxation exercises, visual imagery. Later on they can use heat. I wouldn't use heat right off the bat because you're trying not to let them bleed too much, and you don't want to create any heat so that when you assess you think that you've got a fever and you don't. But you can certainly use all of those non-pharmacological techniques. The next thing that you're going to worry about is promoting wound healing. And that's sort of a really big focus of your nursing care. Usually that patient will come out of the OR, they will have a dressing, often 1 or 2 drains or even a hemovac, and they'll have an elastic ACE bandage wrapped around the wound in a figure 8 kind of way. If that dressing comes off, you immediately need to wrap the residual limb with an elastic compression bandage. If you don't do that, that patient will swell very, very, very quickly, and that's going to delay their recovery. If that person has a rigid dressing, sometimes they have a cast or they have a rigid removable dressing that is applied. If it comes off the stump, remember, you don't have a foot or anything to sort of anchor it in there. If it comes off, the physician needs to be notified right away so that they can recast it. You are going to pay very, very careful attention during dressing changes to aseptic technique because of the risk of osteomyelitis. You certainly don't want to cause this person any more pain or any delay in their recovery, so that, you know, they're going to need to recover for a little while before they can even get into a prosthesis. So you want to be very careful not to give them any kind of infection, and strict aseptic technique. Your book talks about limb shaping, and this was sort of an interesting concept that I found over and over again on the internet. People were really excited about getting their prosthesis for the first time. But in order for that prosthesis to be made, they have to cast it. And before they cast it, they expect the patient has to have some good wound healing, and that residual limb needs to be shrunk. And the way they do that, they have these things called shrinker socks. Let me pause this and see if I can get you a picture of one. Okay, so you shall find I found a picture of a patient wearing a shrinker sock on the residual limb. And you can see in the picture that residual limb is a little bit bulbous. It would be kind of hard to fit that into a prosthetic device. After using the shrinker, it gets a little bit more conical in shape. It's a little bit narrower, a little bit sleeker, and it should fit better into the socket of the prosthesis. So it's important for them to have good wound healing so they can even get to this point. So you as a nurse are going to inspect during dressing changes, make sure that that incision is clean. It should be pink. It should not have purulent drainage. It could have maybe a little bit of serous drainage, and that would be okay, but mostly you want it to be like a well-approximated pink incision, just like any other surgical incision. And just as an aside, let me shrink this a little bit. Let me give you guys an acronym that you can use. You'll see it again in OB, but it really is a general assessment for surgical incisions, and that assessment is known as RITA, and it is a good way to check any surgical incision. You may have heard it in peri-op. I wasn't there, so I don't know. But RITA stands for redness, edema, ecchymosis, drainage, and approximation of edges. Excuse me. Okay, and it's a little bit crowded on the board. Let me move my phantom limb pain out of the way, and maybe enhancing body image there. Okay, so there's your RITA acronym. And when you're looking at any surgical incision, you're going to look at these things. That includes the stump if it was done as a closed procedure. You want to look for redness. Obviously, you don't want any signs of infection, but if you see them, you're going to report them as soon as possible to the provider. You're looking for edema. You really don't want this person to swell, and as a matter of fact, we'll talk about edema in a little bit. You want to keep the foot of the bed elevated if you can, but never ever elevate the extremity on a pillow. Although I did see this in a video on YouTube, don't do it. Your book says, and I agree, that you want to prevent flexion contractures. So although we want to prevent edema, and we're certainly going to assess for its presence, do not try to elevate the extremity on a pillow. The other E stands for ecchymosis. Ecchymosis is obviously bruising, so you're going to look for any bruising at the site, signs of healing. If you see any collection of blood, like a hematoma, you would report that to the physician, but hopefully the drains will get that blood and exudate, give it an exit route so it doesn't build up behind the incision, which would be painful and very problematic. You're going to look at drainage, that's the D in RITA, and you're going to make sure that there is no active bleeding, no purulent drainage, and you're going to look at the approximation of the edges. And one of the things that is a potential complication with amputation as a surgery, if a suture comes loose, that patient can hemorrhage very, very quickly. So that's RITA, and that's what you look for in any surgical incision, including an amputation. So now I can get back to what we were talking about, promoting wound healing. These patients are out of the hospital quicker than you would imagine after having an extremity cut off of their bodies. So you're going to have to teach them how to take care of this stump. This patient may have to rewrap the stump 3 to 4 times a day. They should have several stump socks for when they're ready for that. You're going to wash with mild soap and water. Some other things that will promote wound healing are to place the limb in a dependent position a few times a day to increase circulation to that area. When the stump is sufficiently healed, you're going to teach the patient to do some massage. Sometimes the doctor will tell them to put some lotion on it. Really, you want to teach that person to inspect their wound every day or have someone else inspect it. And this is really difficult for people who have a body image disturbance. So we're going to talk about that in a minute. They need to know to look at that wound and look for bleeding, look for drainage, all of the things that I just told you to look for. Some people can use a mirror to see the stump if it's in a position where it's maybe difficult to visualize the incisional area. People have used their cell phones to take pictures of it so that they can see it. And the advantage of using the cell phone is that if they have a question or a problem, they can text that image to their doctor and the doctor can sort of see it remotely. So that is something that I did see people doing, again, when I was doing the research for this unit. You want to promote good nutrition. Remember, it's protein, vitamin A, vitamin C. Definitely you want to promote enough calories and enough hydration for this person to have adequate wound healing. And those compression dressings or shrinker socks are pretty important. So there's that. And we can sort of move on to the next thing, which is, oh, no, I think I wanted to talk about this. Assisting the patient to achieve mobility. I think I just have too much stuff on this board. Anyhow. Okay, so assisting the patient to achieve mobility. There are a lot of different considerations when you're talking about amputation. And one of them is that the patient can have a flexion contracture. And I want you to remember when we talked about range of motion, the flexor muscles are stronger than the extensor muscles. So when left to their own devices, the flexor muscles are going to pull on that extremity and sort of distort the positioning of it and give you those contractures. So one thing that we don't want to do is to have this person elevate the limb on a pillow. And I know I just said it like twice, so remember it. It comes on a lot of the NCLEX style questions. So and because amputation is a common surgical procedure, you certainly don't want to cause this person any permanent disability. The hip flexors in particular can get very contracted. So we want to make sure that the patient is not abducted or externally rotated abnormally or internally rotated. You can use a trochanter roll to sort of help position that limb so that it's in proper alignment. You're going to do range of motion on the residual limb, and you're going to teach your patient that they need to do this too. Physical therapy and rehab start pretty quickly after. The day after, they're going to get out of bed into a chair. One word about chairs. You do not want this patient sitting in a chair for a prolonged period of time. What you're going to end up with is venous stasis. You're going to end up with edema in that extremity. But they should be out of bed and into a chair. And pretty soon they're walking with assistive devices, walkers, crutches, but they're kind of encouraged to become mobile because another consideration is DVT. Any of these orthopedic surgeries, big risk for DVT, especially for people who have circulatory problems already. You have that sort of perfect combination. You have Virchow's triad, where now you have an injury to the vessel, they've been cut. You have maybe venous stasis from sitting for prolonged periods of time or from being immobile. Remember that this person has serious immobility problems. It's going to be one of your priority diagnoses is impaired mobility. And then on top of that, they may end up in a hypercoagulable state. Diabetes makes people prone to coagulopathies. Dehydration can make people prone to coagulopathies. So, and really post-op patients in general are prone to these problems. The body's trying to conserve
trying to control bleeding, and it sort of increases the production of all those clotting factors. So you really want to watch your risk of DVT with this patient. Having the patient achieve mobility, you're also trying to promote the independence. They may have to use a trapeze. You want to have this person do as much as they can to help turn from side to side. The prone position is really important for people with lower extremity amputations. Prone position will sort of stretch out that hip flexor and keep it in alignment. So we do want to position these patients to achieve like maximum mobility. The other thing that you're going to do to help the patient achieve mobility, let's say, we talk a lot about hospital care, but some of you might end up working, say, at St. Lawrence Rehab, and you might see these patients kind of on a long-term basis. We talked a little bit about prosthesis. As soon as that limb is healed and it's been shaped to the extent where you no longer have any edema, they start fitting the person for a prosthetic device. From listening to these people's stories, it doesn't sound like it's a seamless progression. Like, okay, now you need a prosthesis, we fit it, here you are, good luck, and, go run a marathon with your new artificial leg. It's really a trial and error process. They shrink the limb as much as they can, and they make a socket, they cast the limb, make a socket, and have the person go in it. Now, the prosthesis itself takes a little while to learn how to maneuver it. There can be some skin breakdown. That's why we always encourage people to wear the liners and the socks, the stump socks. They may need it refitted and readjusted, and they need a lot of physical therapy to help them maneuver it. Their balance has changed, their gait has changed. So the whole, process of learning to use a prosthesis and getting that prosthesis to fit correctly and avoiding skin breakdown at the site. Sweating can be a big problem for these folks, and sometimes they don't want to wear their prosthesis. So those are all issues you might encounter in a rehab setting. The other issue you might encounter is that some of these folks, quite honestly, are not going to be good candidates for a prosthesis. They're going to end up being wheelchair bound because maybe they're elderly and their balance is bad and you're worried about the risk of falling. Maybe they just don't have the strength, the physical strength or stamina. It's much harder to walk with an artificial leg than it is to walk with your natural limbs. It takes a lot more effort, and of course, the higher that amputation was, I mentioned it a couple times, the more difficult it is to use a prosthesis, the more effort it's going to take. So assisting the patient to achieve mobility is one of your main goals. And for your interventions, of course, it's early out of bed with assistance, assisting the patient with devices, helping them with their prosthesis. And a lot of these things are going to be collaborative interventions that you see with PT and OT. Also, because walking with a prosthesis is a little bit more complicated, you're going to really make sure that that environment is free of clutter and spills. It can be very frustrating to people to learn to use this and then be constantly falling, so you really want to be careful of that. Along those lines, one of your goals for this patient is going to be to promote as much independence as possible. This is especially challenging when you have upper body extremity amputations. People who lose fingers, hands, even losing your thumb can seriously impact your activities of daily living. Losing digits, most especially the people who have bilateral upper extremities or people who have extremities that are amputated at the shoulder, like shoulder disarticulations. These patients are going to need assistance at the outset, and really probably for a very long time, to feed themselves, bathe themselves, dress themselves, to reach items that they can't reach. It is pretty debilitating to not have the use of both hands. So the nurse really needs to assist and to make sure that there's good family support. And eventually you're going to be working with an OT. If you're really interested in how some of this stuff works, you can go on the Amputee Coalition website, and they show how various people are living productive lives despite maybe upper arm amputations or, other types of amputation. OT can be tremendously helpful to folks in getting them the right assistive devices and training them in how to maintain some independence. So that is going to be a very important goal for nursing care, particularly for people who end up in rehab settings or people who are in home care. So we come to another really, really big topic. Body image disturbance is going to be one of your priority nursing interventions for anybody who has just suffered the loss of a limb. And this is obvious. We talked about it in Human Needs, and we're going to talk about it again, specifically to the person who has lost a limb. Particularly if this person perceives themselves to be young and healthy, and then something occurs that that has them go through this procedure, whether it's traumatic or maybe the person has had some injury that hasn't responded to more conservative treatment, cancer in younger people. So these folks are dealing with the loss of a limb. It's the appearance of the limb, so and also just the loss of function and how people are going to see them now that they are they have this amputation. So one of our interventions, excuse me, I'm sorry, we're going to encourage that patient to look at and eventually to handle that stump. That's the first step, and I'm going to show you some videos in class of people who are looking at their stumps for the first time, and they've shared that information on the internet. And once you see that, I think you'll understand how important it is to get people to sort of accept what's happened. Remember, people are going through a grieving process, and we are going to touch on that. But the first step, they really do have to look at and handle that stump, even if you want to give them time to adjust to that loss and go through that grieving process. They have to be alert for signs and symptoms of infection. They have to start handling that stump, getting the sock on and off. And it's going to be a long road if you cannot encourage this patient to even look at their own bodies. So that's going to be sort of something that you're going to use to help them. The other thing, remember your therapeutic communication. It can be very tempting, especially when you're new in practice and you're young and you haven't handled a lot of patient encounters. It can be really tempting to just try and get their minds off it. And there's nothing wrong with introducing yourself and having some small talk. But if that person indicates to you that they're ready to talk about this, if they start making statements like, I can't believe I look like this now, I look like a freak, or, oh my God, it's not there anymore. If they're indicating to you that they're ready to talk, don't change the subject. Don't shut them up. What you really want to do is encourage them to verbalize. And express their thoughts and feelings. This stuff is sort of the reason that most of us wanted to become nurses, is that, we want to help people who are suffering. And so in order to do that, you really need to use your techniques of therapeutic communication. It's not just for psych. Every patient has psychosocial needs. And especially patients who are suffering from this kind of body image disturbance. So if the patient says, oh my God, I look like a freak, don't laugh and change the subject because you're uncomfortable. You want to maybe say something like, you sound really disturbed about the way your leg looks now. And then let them continue, and hopefully they'll be able to process that. Body image is just as important to their physical healing. Especially because if they don't accept their body for the way it is, they might not take care of it. And so that's something that we're going to work on a little bit more in class. I'm probably going to pair you guys up and have you practice some therapeutic communication with each other. The other big thing that you're going to do for patients is you're going to help them through that grieving process. And my screen's a little bit frozen there. Oh, there it goes. Okay. Well, maybe not. Remember that this is a loss. Limb loss is a loss. So we're going to go through the 5 stages of loss by Elizabeth Kubler-Ross, excuse me. And this applies to any loss. People lose a baby, people lose a loved one, people face the loss of their lives with cancer, but people who lose a limb will go through these same 5 stages. And a lot of times you'll see them, if it's an elective procedure, go through some of them preoperatively. For example, denial. People have maybe been denying that they have diabetes or they have atherosclerosis, or they've been in denial about their smoking habits, even though they've maybe been through a FEMPOT procedure or something like that where their circulatory system is very impaired. Maybe they don't go to the doctor right away when they get a sore that doesn't heal until it gets gangrenous, and now they have to go for an amputation. Now, when they're told that they need to have an amputation, they might say no, and they might sort of not accept that. And so denial is the first stage of grief. Well, let's go down this way. And then following denial, you'll have anger. Remember that sometimes anger that's directed at you as a healthcare professional is not personally intended. It is part of this person's grief. It is part of their processing. Life isn't fair. They could be angry at God. They can be angry if it was a car accident at the person who caused the car accident. They may be angry at you, and the target of their anger might be, my food was cold, or you didn't come with my pain medicine, or what took you so long. That anger should not be taken personally. You should understand that that person is processing some very strong emotions about things. They might be angry at the doctor. Why didn't you treat this sooner? Why didn't you tell me that I could lose my leg if I had a cut? And maybe the doctor did tell them 5 times. But anger is part of that process, and it is normal. And just, again, stay therapeutic. And you don't have to accept abusive behavior, but understand that anger is definitely a part of this grieving process. The next stage is bargaining. And again, you'll see a lot of this more preoperatively. Well, what if I'm really good with my sugars, and what if I take all the medicine, and what if we try this and try that, and let's do another debridement, or let's see if we can try a hyperbaric chamber, or maybe all these things have already been tried. If amputation is really the best solution, but maybe they're going to bargain, or maybe they'll bargain. People have been known to bargain with God. This is all sort of normal behavior for that grieving process. The next phase in the grieving process is depression or sadness. And this is probably where you'll meet this person. Probably by the point they've signed the consent form, they've done their pre-op testing, their reality has set in, they're done being angry, they might not be done being angry, but let's just, say that this is sort of the phase that they're in. And they might be fairly sad, especially the first time they look at that limb. It can be such a shock to them, and such a blow to their self-image, that this is now an irreversible loss. It's not that, this is something that is going to impact them for the rest of their lives. And this is a different than your pathological depression or your depressive disorder, although it can sort of spiral into that without some good support and intervention. But this is sort of a normal phase in the process of grieving. If that person becomes unable to eat, unable to sleep, they're not taking care of themselves, they're not following the doctor's instructions, that person may need some treatment for actual depression, a major depressive disorder. It's sort of separate from what we're talking about here, though. And certainly the nurse who is taking care of this patient in a longer term context, home care or rehab, or through, physician's office, should be aware of the potential for depression, but be aware that sadness is definitely a part of this process, and it's, it's sort of an obvious thing. Acceptance is the last part of this, and you will probably not see this while you are dealing with the patient in recovery, because it can take a very long time, and they might sort of go back and forth between that sadness and acceptance, and but you may see it in patients who have had amputations in the past and are coming in now for some new problem, and you may see it when you enlist peer support, and that's another thing that I want to talk about. because one of your interventions can be to set this person up with support. And there are programs like AmpPeer, especially I think through the Veterans Administration. People can be set up with peers who have had amputations. You're definitely going to want to enlist family support and encourage effective family coping. If you see ineffective family coping, I would encourage you to make that a part of your care plan and refer that patient to the appropriate services. And of course, you're going to be there to support and intervene on this person's behalf. But definitely, I would encourage you to refer this patient to available resources that are specific for amputees. They're excellent in getting people to connect and say, oh, you know, my aunt peer, had this procedure done, and he's able to sort of live his life, and, you know, he's still the same person that he was, and maybe, you know, I can use some of his experience to recover from this. So that is going to be your care planning. Okay, just want you to be aware of potential complications, and I don't know why this isn't moving. There it is. Okay, potential complications, and then we'll be done with amputations, I think. Okay, we talked about phantom limb pain. People also have phantom limb sensation that isn't necessarily painful. And this can be problematic because they're relying on sensory input from an extremity that's not there anymore. So if they're trying to walk with a prosthesis, they're getting information that maybe will affect their balance and increase their risk of falling. So there's that. Of course, in the immediate postoperative period, you have the risk of infection, hemorrhage. Remember, a loose suture, if that's what was used for closure, can cause a massive hemorrhage. There are some major arteries that run down. Let's see. Let's see if I can fix that a little bit. I know the board's cluttered. I'm sorry, guys. I'll be done with this topic in a little bit. So infection, hemorrhage, flexion, contracture we talked about. And the way that you're going to address this for your nursing care plan, your intervention is going to be to perform range of motion, to educate patient, to perform range of motion, to reposition side to side, and then in prone position, and to avoid anything that's going to keep the joints in abnormal states of flexion, like elevating on a pillow. You want to extend the limb as much as possible using trochanter rolls or other positioning aids. If it's a below-the-knee amputation, you want to make sure that that knee is kept in an extended position and then given range of motion. Skin breakdown. And I'm not just talking about the skin breakdown from immobility, although that is definitely always a consideration in a patient who has mobility issues. I'm also talking about the skin breakdown that can occur from the prosthetic device. So we want to educate this person, have stump socks and prosthetic liners, and make sure that when they wash with a mild detergent, they're going to wash their prosthesis. Make sure that it is completely dry when they put it on, no wetness, and make sure it's fitted, and make sure they go back to their prosthetist for adjustments as needed. So those are some potential complications of the post-op period. And now I think we can move on. I thank you for your patience.